introduction. Hope I'm audible.
Yes, yes, doctor. Please go ahead.
Okay, thank you. So I will just start by sharing my screen. So is it visible? Can you proceed?
Yes, yes.
Okay, great. So thank you. Thank you so much for inviting me as a resource person for this said topic. And I know that it's a very important topic, especially for professionals working in healthcare domain. Because this is where most of the stress or be it, patient satisfaction, a comprehensive care model itself, would begin with a good communication pattern. So, and unfortunately, most of the times, healthcare professionals are not very confident with our communication skills. So that's what the research says. And now I would delineate it as we proceed forward. So the moment when we say communication, most of the times what comes to our mind is conveying a message from one person to another. So whenever we talk about communication, whenever we ask a group of people what is communication, we always say that conveying a message from one person to another or one person to group. So that's what defines communication. But unfortunately, what we are missing out here is that it does not end with just conveying a message to another person, but also understanding if that receiver has clearly understood what we are trying to communicate. And that is where the biggest challenge in communication in a healthcare setting pops up. Most of the times, as a doctor, as a healthcare professional, we communicate. We have loads of information that we want to tell to the patients. We communicate. We just convey the message to the patients, and we expect patients to process that information and come back with clearer idea without even verifying whether they understood the information or not. So that is why most of the times we end up in repeating the same information again and again to patients. Patients come back asking the same doubts. Especially this is very common in cancer setting because cancer is a very stigmatized setting. So where patients just blank out the moment we say cancer. So nothing else that we speak beyond that actually gets processed. So patients do come back again and again asking the same information. That is where healthcare professionals also start getting frustrated. So communication, we have to understand that it's not just, conveying a message or a thought from one person to another person or to group, but also so that it can be understood and acted upon. So we have to verify whether the message that we have communicated or shared has been understood by the receiver and whether they have any questions. So this is the first and foremost thought that and clarification that we need to get about communication. So when it comes to communication in medical care, because communication in general, each and every setting has its own complications, has its own domains of communication. But since we are all medical professionals here, I'd like to clearly stick to clear emphasis on with respect to medical care. So, what is the significance of communication in medical care? We are just going to run a couple of blood tests. We're going to treat the patient. So, it all has to deal with a lot of physical aspects. And isn't it just enough for us to just tell the patient that we are going to do blood test or the reports? This is what it is. So, what is like so special about medical care? Is that like most of the times what we do is just medical interviewing, the communication that we do that I was just telling you about, whether telling that okay, this is what the test is, this is what we're going to do, this is what you have to do, this is what you have to pay. So this is just asking them, do you have pain, do you have this symptom, okay, take this medicine. So this is not communication, this is just medical interviewing. But communication is when you start paying attention to other factors that surrounds the information that you're providing. The moment we tell the patient that you have been diagnosed with this disease, we have to understand that the patient is going to deal with a lot of emotions. So the moment you start giving space for that emotion is when the communication gets fulfilled. Otherwise, it's just information, and definitely that's not going to, give us the result that we are expecting. We are not going to, get the patient to come back with so much of clarity. So we have to know that the difference between communication and medical interviewing when it comes to medical care. So it is not just inquiring about what symptoms they have and not just providing the information that we're giving, but also there are a lot of domains, apart from just the information that we have to focus upon when it comes to medical care. So what happens actually in when the communication in medical care is not very optimal is that it leads to increased psychological and existential sufferings among patients. So we have to know that information is very vital when it comes to medical aspects, because first of all, when we put ourselves in the patient's situation, when we are heading to a doctor's clinic and we are waiting for some results to come out, and the moment that we are just so anxious what the doctor is going to say, the moment that the doctor is just providing some crisp information and not in detail, not explaining in detail about what the condition actually is. You've been diagnosed with cancer, so you have to take chemotherapy, you have to do this. So this is providing information, but the patient is going to have so much doubts, as in what exactly is cancer, what is this type of cancer, like is this curable, or is this what exactly is the nature of this disease, is it an aggressive disease. So they are going to have scope for so many questions there. So when that is not being fulfilled, when there is a deficiency in the communication between a healthcare professional and a patient, that is going to eventually lead to increased psychological as well as existential sufferings, especially, not only with patients, but also with their caregivers as well. So this patient and patient and physician communication is very, very optimal when it comes to healthcare profession. So what do we call as, patient centered care? Like, when does a patient centered care gets fulfilled is when we have a patient or a family who is very much informed and, participatory in decisions. Meaning, when a patient is completely aware of what is going on with him or her, and whether they are given space to voice out what they want. When we have such a patient or a family, and again, another component is when there is a very responsive and organized healthcare system. And the third component that is important is to have patient centered communicative clinician, meaning a clinician who is ready to answer and address the concerns that are raised by the patient. So with these, we need to have a patient who is ready to be involved, and a healthcare professional who is ready to involve the patient, and organized healthcare system. Only when these three are there together, that is when a patient-centered care can be achieved effectively. So for all these three components, an effective communication pattern is very, very important. So when these things happen, when eventually the communication pattern is also improved, and eventually the healthcare outcomes are also improved. So, not only in terms of benefit for patients, but also in terms of healthcare professionals. So we know that most of the times we deal with patients or families coming and knocking at the door repeatedly, asking about same thing, same questions, such as is will this settle with radiation? You said you have to undergo surgery, so how effective is the surgery? And do you think surgery alone is enough? So you would have explained, you would have spoke to the patient, caregiver, everything about the treatment plan. They would come back with this. So again, you would, provide blah, blah, blah information saying this, yes, surgery, you have to do this. And then after this, we have to check, and then we'll decide, blah, 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 everything. And then again, you send the caregiver out, again, they would come back. So what happens is, this is not only a burden for the caregivers, it is also equally a psychological burden for the healthcare professionals, because you have so many patients, waiting to attend to you, or you need to, apart from patient care, you'll be having so many things going on, academic research activities. Despite all that, attending to the same patient or the same concern again and again, same patient, different concerns, fine, but the same concern again and again and again would definitely lead to a lot of burnout and also work related stress. So that would create a lot of frustration with healthcare professionals. Obviously, we would end up showing that frustration to the next patient or the next next, colleagues or whoever there is, because we would be dealing with the same things again and again. So when and communication pattern is very effective when the patient or family steps out of the clinic with satisfied information, then that itself would reduce a lot of time that you're investing in the same patient for attending the same consult. So that would eventually lead to a better quality of life with healthcare professionals as well. So just small changes that we're going to do with our communication skills will help us improve our well-being and quality of life to a greater extent. So when it comes to when we speak about, so to attain this, like, to get reduce our healthcare burden, like, stress levels. So what we have to do is we have to attend to few components. So when we speak about patient clinician communication, so there are six core functions. So what exactly do we do here? So what is the role of a healthcare professional, and what are the components of the communication that we actually engage in here? Are six major things. So starting from exchanging information. So the first component of the clinician communication is that we are exchanging some information. You're either telling the patient whether, you've been diagnosed with this is what the treatment is, and this is what we are going to do. So you're exchanging an information to the patient. And another next component is making decisions. So with informations, so what happens is you're either involving the patient into the decision making, or the family, or you're telling what what is it that you're going to do for the problem that has arrived. So we are making decisions either in an interactive manner. And next is fostering healing relationships, meaning sometimes, when we are communicating, we'll get to know that the patient and the family are dealing with a lot of interpersonal issues because of the situation that has arrived, because of a cancer diagnosis, because of a disease with a chronic illness. So in such cases, most of the times when we communicate, and moreover, getting the patient's trust, and patient has to get that comfortness with us for us to, so that they can ask any questions that they want, or at least communicate what is it that they need, so they can be vocal about their needs and their care options. So such relationships, so the once communication is in a better process, so eventually, be it interpersonal relationships within the families or the patient professional relationship, so it all comes down to a very good rapport process. And the next is enabling patient self management. So our communication should also focus on enabling the patient to choose what is their care of plan that is required. So what is it that they want, and also you're preparing the patient to deal with things. So you're not just putting things and responsibilities on the caregiver's hand, but by providing information in the right manner, we are also enabling the patients to deal with their own stress, deal with their concerns that they want, and so that they are able to manage the things that they are going through. So you are encouraging to develop a very healthy coping mechanism also. So, and the next component of our physician communication is managing uncertainty. So this is very much aligned with exchanging information. When the patient is having a lot of concerns, uncertainties, eventually providing the information is going to help them manage the uncertainty and plan for a better care. And then responding to emotions. So meanings, when we start providing adequate information, and when we are eventually addressing the concerns that the patient is coming up with, so slowly we are, directly or indirectly, we are going to address the emotions that they are dealing with. It could be fear, it could be sadness, it could be anger. So providing the right information along with addressing respective emotions is going to help the patients develop a better coping strategy. So these are the main components when it comes to healthcare communication. So what we achieve by modifying or following a better patient-centered communication is that we are going to get enhanced patient satisfaction, and eventually their increased quality of life. So this would be attained, in line with reduced anxiety and also improved symptom control. So when patients are having control over the information that they have, or patients are getting to know that this is what I'm going through with, this is what, my condition is, and this is where I'm going to end up, or this is what my treatment is going to be. So once they have the control over their health and their treatment plan, their adherence to treatment also increases. Most of the times you would encounter patients with non-adherence issues when they don't exactly know what's going to happen. When we tell them that we are going to do a couple of radiation, following which we are going to do surgery, and then patient does not exactly know why is the radiation being given before the surgery, what is the need for this medication. So if these things are not known, so eventually the patient is going to get anxious, and that would lead to a lot of non-adherence issues. So once providing these information and helping them to cope with that information is going to help with increasing the adherence to treatment, and helping them to get more improved understanding related to their diagnosis, and also regarding their prognosis. And also, even as I said earlier, we are going to have decreased oncologist stress and burnout, healthcare professionals stress and burnout levels. So, actually, this was an outcome of a study, a survey that was done. And so, when they did a survey with patients in end of life care, asking them how many of the patients recalled or remembered that the patients actually discussed regarding their end of life preferences. So, only 38% of the patients actually said that, my doctor discussed with me or asked me what is it that I want during my end of life phase. So, remaining 62 percentage of the patients did not remember or recall anything that as a clinician was discussing with them. So most of the times these discussions happen, unfortunately, with the family, neglecting the patient's, patient's physical health or their mental status. So only 38% of the patients had this opportunity of discussing their preferences. This is what I want to do. This is where I want to be during my treatment phase or during my end of life. I want to be at home. These things, most of the times patients are not given an option to. So, and yeah, yes. So, since I'm working from in a cancer setting, so I'd like to emphasize a little bit about cancer care. Like, what is special about cancer care? Because usually we deal with a lot of bad news over here, breaking the bad news. So, what exactly? So, these are the components of communication that we spoke before. So, but what exactly is special about cancer care is that cancer, as we all know, it's a very stigmatized word. The moment we say cancer, patient is going to be completely blanked out. The same with the family also, because it is considered a very life-threatening situation with a prolonged treatment plan. And also, clients, like, they once they are diagnosed with distress, they immediately they start experiencing a lot of distress, and the communication is it plays a very key role when it comes to cancer care, because half of the time all the patient patients need is all the information about their diagnosis, treatment, and prognosis. So most of the times, that would be the major cause for distress in a cancer setting. So because once like breaking the bad news is like very literally considered equal to dropping a bomb. It's just you're just dropping a bomb on the patient, and then we're just leaving them helpless to deal with it by their own. That is where patients start developing a lot of distress. So disclosing a bad news does not end with just providing information. So when there is a gap between patient's expectation and the medical reality, that is when the information is considered as bad news. For example, a patient they have given all their biopsy and tests. They are just waiting there and they are expecting that it should not be cancer. But the medical reality is that it's going to be cancer. So any information that is going to be, opposite to what the patient is expecting will be considered as bad news. So bad news should not be defined as per the healthcare professionals decision, because for us sometimes a cancer diagnosis with a good prognosis might be considered as a good news. So we would say that don't worry, it's a very early stage breast cancer, so it should be fine, but the patient does not want to be diagnosed with cancer at all, so their expectation is completely different. So for us, this may be considered as not so bad news, but for patient, it is still considered a bad news. So we have to know that any news that is going to come, with in opposing to the patient's expectation is considered as bad news. And so yeah, so this is just to show what exactly a patient hears, when we disclose the diagnosis or the treatment plan to the patient. So everything else just becomes blah for the patient. So it'll only be the patient's attention only will be towards the word cancer. Everything else, it's like even if you keep telling that, it's going to be just 3 months of treatment, and then after that you can be all back to normal, blah blah blah. Everything is going to be just just some just blahs, but not doesn't make sense for them except for the word cancer. So this is what happens. This is what goes through inside mind of a patient or the family when we are disclosing a bad news to them. Okay. But this bad news can also be managed when the communication style is good. So that is why we have know why good communication of bad news is important. So the news is always going to be the same, but the way we communicate it and the amount of time and emotion that we invest into communicating a bad news is going to be vital when we are hoping for the patient to get improved understanding. So when all does breaking of bad news becomes very stressful is when the physician or the healthcare professional is inexperienced, where we are not very confident, and we feel that mm, we cannot always be the doctors who give only good news to patients, right? So especially when we're dealing with chronic illnesses, it's going to be most of the times it's going to be bad news. So when the doctor is not very much experienced with dealing with such situations, and when the patient is very young, because most of the times healthcare professionals have said that they feel very comfortable disclosing a bad news to someone who is above 45, 50 years old, because we get the feeling that they have lived enough and they feel like no, not so broken when we are disclosing a bad news. And that when a patient is very young, we empathize with them a lot. So we feel that they are just they've just completed their schooling, they just got married. So we empathize with them a lot, and saying that they have still more things to see and more life to live on. So when the patient is very young, then breaking the bad news becomes very stressful for a healthcare professional. And when again there are limited prospects for successful treatment. So even though disclosing the diagnosis of a cancer is considered a bad news, when we have some hope that there are some treatment options that which can give us like good success rates, when we feel that the prognosis is going to be good, we feel little confident. But when that is also out of option, when we feel that it's going to be an advanced disease and the treatment options are very limited, that case again breaking bad news becomes slightly difficult. So at least, because we always need to have some positive components even when we are speaking about a bad news, right? So when everything is going to be completely negative, then that puts a lot of stress on healthcare professionals when during such scenarios. So, and most of the times, physicians or healthcare professionals, they have said that they feel very unprepared for communications with patients, especially when they are towards their end of life care. So, majorly because inadequate time during their visit, because we always see that there are going to be like more number of patients. So I don't feel that I have time to spend so much with one patient because I have so many patients waiting. So inadequate time I do not have, because end of life, obviously the patient is going to come up with a lot of emotional concerns and so many psychosocial issues that they want to my support with, but I don't have time for that. And again, another thing is that they are rarely trained in techniques for giving bad news. So I think now that the education system is that every healthcare professional, every academic syllabus includes chapters on communication skills training. So but then again, it's all theoretical, but what we lack is more practical. So we know that these are the steps. We know spikes. We know case breaking bad news model. So we know everything by heart. But when putting into practice is what we lack. And physicians often experience negative emotions. So most of the times what happens is it's not just, again, physicians are not just focused on the information, but also about, they deal with a lot of emotion when they are disclosing a bad news. So when I'm going to tell that I've been treating a patient for this long, and now I'm going to tell the patient that eventually the treatment has not been effective, and they have not been the symptoms have not improved. So now we don't have any option, that but it's going to be only just best supportive care. So curability is not going to be an option. So when I'm going to inform this to the patient, I am having a fear that they are going to blame me, whether they are going to tell that you have not saved my father, you have not saved my mother, why did you do this? So the physicians also deal with a lot of emotion, as in when they are disclosing a bad news. So this also prevents them from initiating a communication about this. And also when they are worried that when a patient starts crying, or when a patient or a family starts breaking down, that the physician might react to their emotions by providing false hope or premature reassurance. So, meaning that the moment they start breaking down, it's all the humanity that that comes up, that we just want to say that don't worry, things will be fine. There would be some option. We'll look into it. We'll see. There would be something that could work, possibly work. So some false hope or some premature reassurance, which is not going to be possible. So that is again a concern that physicians, repeatedly state. So that is why I do not engage in conversation, because I know this is what is going to come into it. And so again, disclosure, but again, not complete disclosure of the information. So the physicians tend to omit certain important information which they feel that they are vulnerable for some emotional reactions. So they just omit those components and just focus on the informational aspect alone, which is going to be just more of practical component. So these are the things that physicians have repeatedly reported, that they face difficulty whenever asked, why are you not engaging in that conversation, or why is it difficult for you to initiate a conversation about a bad news. So but then the same thing was done with the patients. So when patients were asked to rate what they preferred, when they were given the news about diagnosis, what they wanted when the doctors discuss about such scenarios, is that the doctor informing the patient about best treatment options and taking time to answer all the questions. So they wanted the doctors to give the time and give space for them to ask questions. They I have so many doubts, and I want the doctor to just patiently answer my doubts. Just that's it. If that was done, then half of my distress would be resolved. So again, the next thing that they wanted was that doctor being honest about the severity of the condition. Yes, it is true that being honest about, or being open about the severity of the condition, if it is going to be very poor prognosis, that's going to have a lot of emotional reaction. But the patient would always, most of the times, they want to know what exactly is going on with me. Am I going to die? Am I not going to get cured of this? So because just leaving it at that go and not answering that doesn't make that question irrelevant, or doesn't answer the question. So it is only going to give space for more assumptions. So instead of that, patients want to know, just can be honest and tell us that this is what it is. At least I would know that this is the information and I can deal with it. So, and again, they're expecting the doctors to use very simple, clear language, giving the news directly and giving full attention to the patient. So these are the small things that the patient expects from the healthcare professional when a news is being given. Like, do not use medical jargons. Do not beat around the bush. Just you can be open and tell me that this is what it is, because the patient is already anticipating that news. They somewhere suspect that this is what the doctor is going to say, and they are just validating the information that you're providing. So in that case, using jargons and playing with words is not going to help them. So they just want the news to be given directly in clear and simple language with full attention and giving space and time for patients to ask questions. So this is what the patients are expecting from healthcare professionals when it comes to medical communication. So a few things that we have to keep in mind during when it comes to communication is that before you initiate a communication, so just think about, why am I communicating? Like, as in, what is the purpose? So am I here to disclose the diagnosis? Am I here to discuss the treatment plan with the patient? Am I here to address their emotional concern? So what is the purpose that I am here to meet the patient for? And again, the next one is, who are the people I'm communicating with? Am I speaking to the patient? Because patient's psychological, psychosocial state is going to be completely different from caregiver's state of mind. So, is it the caregiver? Is it the patient? Or is it some relative? Or is it going to be other healthcare professional? So who exactly are the people I'm communicating with, and we have to tailor our communication style according to the recipient. So if it is patient or family, then the language has to be very much simplified. Or if it is going to be another healthcare professional, then again it has to be completely different. So you have to identify who the recipient is going to be, and what is the purpose, and what am I going to communicate. So I know that I'm here to disclose the diagnosis to the patient. That is the purpose. So what am I going to communicate? Meaning, what exactly am I going to tell? So am I going to tell about the investigative procedures, or am I going to just tell that you've been diagnosed with cancer, and this is the stage and this is the treatment plan? So what exactly am I going to say? Or I'll just focus on speaking about the diagnosis today, and probably give time for them to process, and then probably next session or later after some time I would come and discuss about the treatment plan. So you have to plan exactly what is it that you're going to communicate, and how am I going to communicate? Meaning, am I going to involve the family also when I'm speaking with the patient? Or am I going to just, give all the information at one go? Or am I going to break it and say, and tell them that, you've been diagnosed with cancer. So how do you feel? Am I going to give spaces in between and understand how the patient is doing, and then proceed with next information? So what exactly is it that I'm going to do? So communication or breaking a bad news is not just a simple process, because the recipient is going to deal with a lot of things based on the information that is being provided. So a healthcare professional should put in a lot of effort and emotion before actually coming with a proper plan of communication. But then the focus should be on these things as I listed now. So we all know that there is always when we speak about communication, what are the methods of communication? We all know that there is verbal communication, non-verbal communication. So these are the common things. We always say that it's either written or message or visual media. There are so many things. It all classifies under verbal and non-verbal communication. But in healthcare profession, another type of communication that we have to give due importance is absence or silence. Because most of the times, what happens is, like, when we are not prepared with answers to patients' questions. So sometimes when you go, the patient would just throw out a question to your face saying, this doctor, just be honest with me, am I going to die? I just want an answer. Or am I going to be am I going to get cured or not? So just be honest with me. So if that was the, a question that is put forward to you out of the blue, and you're not prepared to answer that question, so what happens is, most of the times we either ignore that question, or you just start initiating a conversation about something else totally. Or sometimes we just step out of the room saying this, that you would come back. So what happens is, you would come back thinking that, thank god I didn't answer the question. You go and tell your colleague saying this, I was just silent, I didn't answer that question, I didn't know what to answer, so I just did not want to touch that question, so I skipped that question. So this would be your response, right? So, but we don't understand what goes on with the patient or the family, after your silence. Because what happens is, silence can always be interpreted in multiple ways. So from the patient's point of view, the patient would be thinking that even if it is like, a disease with a considerably good prognosis, the moment you don't answer and you ignore that question, patient would start thinking the worst. They will say this, why didn't the doctor answer my question? Why did the doctor say anything? He just, skipped that question. He just left the room. So he did not say anything about my doubt. So then they'll start interpreting that in different ways. They'll probably start thinking that, probably I think then it's not a very good news. I think I might not be cured. That is why doctor did not answer my question. So they'll start building upon their assumptions. And that is not a very healthy style. So either absence or silence is very dangerous, type of method of communication. So instead we provide the information, or at least reassure. If you are not equipped to answer that question, if the patient is asking something, at least tell them that, I'm sorry, I know I do not have adequate information on this, or I'm sorry, I think the doctor would be the right person, or I'm not very confident about this information, so I would discuss with your healthcare professional or your treating physician, I would get back to you. So you have to address that question instead of leaving it silent or blank. Yes, because that could be interpreted in n number of ways, and that interpretation would not be a very healthy style of coping. So to all this, like we until now we've seen like what exactly is medical care communication and what are the components. Why do we need a good communication, and what is the importance of communicating a bad news? So one thing that is very significant that I would like to touch upon is listening, because communication always it like starts from listening. So once we like enhance our listening skill, eventually our communication pattern gets very much, it falls into the right place. So most of the times, if you see like any like leave alone successful people, sometimes even with your friends, you would have everyone would have n number of friends, right? But still we all feel very connected and very close with only few people. And when someone asks, like, as in why do you feel so comfortable with this person, why do you feel so comfortable with that person, the thing that automatically most of us would eventually say is, she just whatever it is, whatever I'm going through, I can go and just vent out to her or went out to him. Like, I know she just listened to all my stories. So that is the power of listening. Most of the times, most of us do not expect solution for our thoughts, for our questions. Most of the times, we all need is a listening platform. We need is a catharsis. So and listener is always considered the best therapist. So in counseling we always consider this as the first and foremost skill that every counselor should possess. So that's the same for healthcare professionals as well. So effective listening is what is the first key step to an effective communication skill. So but most of the times we do not listen effectively. That is where our communication gets hampered. Like, why do we, what are the blocks to an effective listening is that one is inattention. Okay, and distraction, meaning, see, when a patient is sitting in front of you and you're already preoccupied with, like, some thoughts of your own, or there is something happening at the background, or you getting a phone call. So you're distracted and you're not attentive to what the patient is telling. The patient would be telling so much about or opening up about their concerns, psychosocial concerns, or their emotions, but we fail to pay attention to it and we miss out those vital information, and we just move on to the next information. We start providing our own set of information that we have prepared. So this inattention and distraction is like that this is very common in our day-to-day practice. Like we have seen this often. But just put yourself in a patient's position and think for a minute. When you're speaking to someone, where be it your friend, be it your colleague, and if they are not attentive, and if they are on their phone, or if they are just looking somewhere, so you would, we would definitely feel very frustrated. When like, I'm talking to you, just look at me, just listen to me, could you keep your phone aside? So this is what we would tell them. But the patient cannot say that. But what happens is all of these would be observed by the patient. So patient gets very, uncomfortable, and they would be that the doctors are very busy. So I should not probably, ask more questions. So they limit themselves from asking questions if they have as well. And again, bias or being judgmental. So this, like, for example, when there is a tobacco user or a substance user who's sitting in front of you with a cancer or a chronic illness. So we, the moment that like as a healthcare professional, that we should not be judgmental. But some scenarios, the judgment starts coming and say that probably he should not have smoked. He's been smoking these many things, and that's why he ended up with the cancer. So these things would be like, going on. And if such a thought occurs, that would definitely hinder our listening skill, because that would act as a barrier. And obviously, the healthcare professional cannot be very, there would not be unconditional positive regard in this scenario. And excessive talking, so not giving space for the patient to ask a question, or if the patient is speaking also, like, we stop cutting in between, and because we just have to finish off the session and then move on to the next patient. So you just provide so many information, and you'll be like, just a minute, I'll just tell all these things, and later if you have any doubt, we'll discuss it towards the end. And we do not give space in the end, for the patient to ask questions. So excessive talking from one side, so also acts as a block. And faulty attitude, there will be a lot of attitude in a blocks itself with the healthcare professionals, or so which prevents us from being very open, or like, to receptive, being very receptive to information. And as I said, personal preoccupations, when we have something personal issues going on and all of these things are sitting on our mind, obviously that would create a block to a block as a block to effective listening when it comes to patient care. So, how exactly do we show that we are actually, listening? We have to convey to the person that we are observing what they are telling, and we are very much interested in what they are telling. So that first is look at the person who is talking. So just imagine if you're talking to someone and they're not maintaining eye contact, they are just looking around the room, and you're just, especially when you're very emotional and when you're very vulnerable and you're speaking something very sensitive, and they're just not looking at you and looking somewhere, staring somewhere, looking at their phone. So that would not create a very comfort zone for you, right? So you would immediately stop talking any further. So all maintain eye contact is the first thing. So eye contact always, gives them the reassurance, assurance that the person is listening to what you are telling. And if possible, lean forward. So because leaning backward and sitting very comfortably in the chair, and like, with legs crossed and sorry, folded hands. So these things indicate that we are not interested, and probably that the other person is very, like, you just want them to stop talking, or you're just not interested in listening to them. So if possible, lean forward with open hands. So do not cross your hand and keep it open, so that open hands always indicate that you're open to information and you're listening to what they are telling. And ask questions. See, for example, if the patient is telling something, and if the patient is keeping like, going on and on for about 15-20 minutes, and you're just quiet, and you're just looking at them. So sometimes in between, the patient will start wondering if the doctor is listening to me or not, and they would start telling that, I'm sorry, doctor, I may boring you with all this information and all of these things. So but when you step in between, and we just give a small head nod and say, and if in case, even if you have already understood what they're telling, if you're just posing a question from that. So you said that you underwent biopsy outside hospital, right? So am I right, did you go to this hospital? So if you just ask question, then they'll know that, oh, she's listening to me. So I'm like, she knows that I said this. So they'll be able to understand, be it asking question or be it summarizing their response. So just once in a while, summarize what they said. So I understood that I understand that you've been going to all these places. I understand that after getting cancer that you've been feeling this way. So just rephrasing what they have said or asking any questions in between also shows that we have been actually a good listener and that the patient is being heard. And also stick to speaker subject. Do not jump onto some random subjects, because sometimes what happens is the patient would be very emotional speaking about their family, speaking about the daughter or someone. And if we are jumping into some other subject saying this, actually I also had one of a colleague, and she also had a daughter of this age, but then her daughter who is married right now and she's blah blah blah. That is not relevant to the speaker subject at all. So always stick down to speaker subject and say that, if you do not have points to add, just as I said earlier, rephrase and ask question and stick to the same speaker subject. So, and so few ways that we can actually show, few other ways that we can show is always remain very relaxed, in a relaxed posture. Do not look very anxious. Do not have very um closed fist and very strict, and do not sit on the edge of the seat. So always maintain eye contact, as I said, smile and nod. So once in a while nodding our head indicates that again we are with them, we are traveling with whatever information that they are telling. And being empathetic. So empathy is a very important skill for every healthcare professional, because sympathy, as a human being, we all have sympathy by nature, but empathy is a skill that should be developed and it should be practiced regularly. So while sympathy is feeling sorry for someone, and empathy is where we are placing ourselves in the patient's position, because once you place yourself in the patient's position, then you would automatically you would give all your attention to the patient. So if there is a 50-year-old lady sitting in front of you diagnosed with breast cancer, and she is a single parent, and she does not have any other family support. So once you empathize with her, once you place yourself in her shoes and see the situation from her side, say how would she feel if I was her, how would I feel if I have a daughter and a single parent and I'm dealing with all of this, what would I feel? Then obviously, even like automatically all our attention, everything would go into the patient, and you would be able to do justice in an even more effective way. So sympathy, yes, it is required, but empathy is required even more in a healthcare setting. And again, we have to speak very slowly and very clearly, as we discussed earlier, and also ask for others' opinion. So meaning, once you provide any information, always have you have communicated something that you wanted to tell to the patient. You've done that, and towards the end, always ask for their opinion. Ask them, is there something have you understood everything? Is there something that you would like to know? Is there something that you want to know? So always give the space for asking questions. And if there is something that you have done wrong, it is okay. Accept criticism, because sometimes we might have given some wrong information, or we might have missed something. So probably when the patient or someone is pointing that out, saying this, no, but the doctors have said this, but you're coming and telling me this. So yesterday a doctor came and she said this, so but why are you telling me this way? So if that was the case, if you feel that that's something wrong that you have done, accept criticism, and you can always accept it with the patient and say this, I'm sorry, I might have missed this point, or is it so? I'll definitely look into it, and if that has created some confusion, I apologize for that. So accept it when we make mistakes, because no one is very good at everything. We cannot always be very good expert in communication. So sometimes this does happen, but it is okay to accept and move forward. So these we have already covered, and just would like to touch a little bit on what are the barriers to communication. Meaning, because earlier we looked into what are the barriers to effective listening skills, But again, here barriers to communication is something that I would like to touch upon. So first one is filtering. So again, selectively choosing certain information and providing that information alone and not touching the aspects which are very sensitive, not touching the aspects which are very vital, but again involves emotional components. So filtering such information out is again not a very good, this is a very serious barrier. And same thing, when a patient is speaking to us, we again filter out certain information. The patient would be speaking to us about, I was very scared when the doctor said this. And then again, we went to this hospital. And again, there also the doctor said that. Again, we came down to this hospital. So we ignore the information, we filter the information which speaks about the fear component and touch only about the components which are also you have moved, you have shifted to three hospitals, is it? Okay, so what exactly tests did you undergo in the first one? What did you do in second? What did you do in the third? So we just filter out and pay attention to the information which we feel very safe. So that is biggest barrier. And again, selective perception, meaning so again bias, focusing on like where exactly the patient comes from, and again their personal characteristics, oh, she's a tobacco user, oh, he's this person, he works this here, he's that kind of a person. So all these things, so selective perception, and that again acts as a barrier. And again our emotion, which we already said before. And language, again we have to pay close attention to language, because being in India, with where we have multiple people with multiple backgrounds and multiple languages. So I think we have to pay a little close attention to it, and think, yeah, distorting information. So yes, just this is the last slide, just winding up here. So what not to do, because in the next session we would be focusing on how exactly we would be breaking the bad news, and what are the factors to consider, and how to handle like each and every emotion that comes up during breaking of a bad news. So that would be handled in the next session. So here I would just like to conclude by saying what are the things that we should not do, because we have seen so much about what should we do and why is it important. So what exactly should we not do in communication is that one is not moralizing or do not bring in philosophy, and avoid comparison, like do not compare any patients with another patient. Tell that, even I have dealt with this, or this patient is doing so good, why are you not able to do that? So no comparison when it comes to communication. And again, meaningless statements, just as a filler, so we cannot just keep coming up with anything that just does not make any sense, and using jargons and fake and false reassurance and assumptions. And also forcing our belief on the patient, so do not confront their emotion by stating that. We should not be again say, if the patient has a different belief system, we should not be again putting our belief system onto the patient. Sympathizing, again, try to avoid sympathizing. You can use a lot of empathy. So empathy can be communicated with a lot of statements like, I understand what you're going through, I understand what you're telling, so I see that you're feeling this way. So that is empathy. So you can use empathetical statements, but avoid sympathetical components. And inappropriate humor. So again, when the patient, be it any scenario when it comes to medical communication, do not use humor unless and until you're very confident of it, because humor can always be interpreted in a very condescending manner. So do not use humor unless you feel confident about handling it in the right way. So yes, with this I stop here.
Thank you, Dr. Revathy, for such a wonderful presentation on communication part one. So, participants, I think now you can post your questions in the chat box. We can take it up for the next 5 minutes before moving on into the case presentation. And for the case discussion, we have Dr. Surendran Viraya joining us today. So, I have posted in the chat box also. So, he'll be handling the case discussion along with Dr. Revathy. So, participants, please post your questions, and for the next 5 minutes, we can take it up. Anybody would like to raise your hand, unmute and ask, that is also fine. I can read it out for Dr. Revathy if something comes in the chat box. Yes, so we have one question from Dr. Vincent. Sometimes I have to explain several times to the patient's family because the person being explained changes. For example, today to the patient's wife, tomorrow to the patient's cousin, the next day to the patient's sister. This is very annoying for me. Do you have any suggestions?
Yeah, true. Actually, this is a very common scenario that we also face a lot because when when it comes to diseases with chronic illness or a serious scenario, there will be a lot of people who are involved into the process. So and they would just keep changing. So what we do here is we insist upon they can come. But again, we always insist upon having one constant caregiver who would be the primary decision maker. So on the first day itself, we would clearly ask and discuss about that, like who is going to be the decision maker for this patient, and then they would be the point of contact. So even if the patient the next day some other caregiver comes and asks questions, if it is going to be again something very a small concern that they are asking, that is fine. But if they are going to ask about the entire treatment plan again, we emphasize saying that this has already been discussed with the patient and to this person who is the primary caregiver. I think you can have a discussion with your family and then come back and ask if you have any additional doubts for them. Because again, yes, repeating the same information to them again and again to different person, that's going to take up a lot of time, and and involving too many people into the decision making should not be very ideal thing. And also otherwise, you can on the day one itself, you can ask the primary caregiver if there is any other significant person who is going to be involved into the decision making process. If that was the case, like once we can all meet together and then I would discuss. Or otherwise, who would be the decision maker, who would be the primary caregiver, for them we would be discussing about this. So we also do not pretty much encourage speaking about the same thing to different caregivers each and every day. So I think as a healthcare professional, we have to be quite assertive on that, because obviously there are a lot of patients who need your time. So that should not be the case. So we can always ask them who are all the healthcare professionals going to be primarily involved in decision making, and then please you and whoever that is, you can come together and then I'll discuss about the patient's condition. I
Yes,
think
thank you, Dr. Revathy.
Thank you,
Dr.
ma'am.
Dilip, Dr. Dilip, can you please go ahead?
Dr. Dilip has posted the question in the chat box. Yes, so many times patients, close relatives insist not to inform about the disease to patients. So like children's for their parents, husband for wife, etc. So this is actually what to say, a very unique question, because this is what happens in our culture, in Indian scenario, in our medical setting. In our medical setting, the scenario is completely different, because the generally the medical ethics always informs that the patient should be informed about their healthcare condition, and only if the patient consents, then the information should be disclosed even to the caregiver. That is what the actual practice is. But unfortunately, ours being a very ours not an independent individualistic culture, so we are a collectivistic culture. Yes, true. In India, it's very much reverse, wherein it's always the caregiver who's first being informed about the diagnosis or the prognosis. And only if the caregiver wishes, the information goes to the patient. So that is how the actual scenario is. But uh, thing is that what we ideally suggest is, not all the time patients want to know all the information. So every communication model that we would be discussing, we would discuss a few communication models in the next session. So every communication model and every practice actually indicates that whichever patient wants to know, if the patient wants to know what is going on with them, then it is the duty of the healthcare professional to disclose the news. Again, that has a lot of components to it, meaning how much the patient wants to know, and what exactly the patient wants to know, and how much the patient already knows. So these things should be evaluated. So if the patient, for example, says that I just want to know if it is cancer or not, I don't want to know anything further, don't tell me, like, because I'm just scared of the word cancer, so I just want to know if it is cancer or not, just tell me that, doctor. So nothing else remaining you discuss with my son or daughter. So if that's the case, then you cannot force the information onto the patient about the treatment plan. So you cannot say this, like, yes, it is cancer, but again, you have to know what you're going to get treated, because the patient does not want to know, patient feels overwhelmed. So in that case, like, again, if the patient is not prepared, we should not force down the information onto them. Again, if the patient wants to know about the treatment, then it is again our duty to discuss the treatment options with the patient. So, but in between this, that is where the caregiver comes and stand. Caregivers will be literally, in our setting, caregivers would be literally standing in behind the patient's bed, and they'll be showing hands saying, don't disclose, don't say anything. So that would be the state of the case. So we have to clearly understand why the caregiver is doing this, because most of the times they just want to buffer the patient's distress, because they are worried that you are going to break the news to them and you're going to go. They are going to deal with the after effects. The patient is going to cry, the patient is going to get broken down. So what would they do? They feel helpless of, like, helpless of how they are going to deal with the patient's emotions. So that is the case, that that is the reason that they do not want the information to be broken. If you just ask them why you don't want the patient to know, they would tell that, she would be broken, she would cry, she would feel hopeless, so don't tell her. So you have to give them the confidence that, like, you would, like, not just do the damage and go, but would always, be there, that ensure that the patient is coping adequately with the information provided, or at least provide the information to a smaller extent, so that the patient can at least process that. And also, you have to, like, involve them in the process. You can tell them that you can also be there when we discuss about this, and you can see that these are the things that we are going to discuss to the patient. And I think, we have to tell these information. Also, you have to tell them that what is the importance of disclosing this, especially when the patient wants to know. Because if the patient, as a patient, I want to know what is going on with me and I'm not told, I can assume anything. I can, it would be just, a cancer which is very much curable. But the caregiver does not want to disclose. The doctors are not telling anything. I can assume that I'm at the worst situation. So that is not, good for the patient's psychological well-being. And even if it is an end of life care, even if the no that was the scenario, still, if the patient wants to know, it is very important to disclose, because only then we can discuss about what are the unmet needs that the patient has. So all these things, I think, we need to have a very detailed session with the caregivers alone. Understand and acknowledge. Do not confront. Do not tell the caregiver. Do not like, oppose the caregiver saying this, no, no, you have to tell the patient, you cannot no, hold the information. You have to acknowledge, you have to tell them that I understand that you're doing this to protect the patient, I understand that you're doing this for her good, but withholding this information is going to cause even more psychological distress. And that is where, I think providing this information at least would help us to get some information, or to understand how she's feeling about it. And we are here through the process. I would be here to help you to speak and discuss about this with the patient. So you have to provide that reassurance.
You, ma'am, for that detailed explanation. So participants, as of now, I think we can move to the case discussion and then take up questions after the end of case discussion. So we have Dr. Kalyani joining us for the case presentation today. I welcome you, Dr. Kalyani.
Yes, Dr. Farzana.
You can go ahead, Dr. Kalyani.
Yes, hello everyone. My name is Dr. Kalyani, and I am working as a medical officer under Directorate of Health Services, Goa. So, my patient is an 82-year-old female who is diagnosed with hypertension, diabetes, ischemic heart disease, and she also has a right ovarian malignancy. So, before I proceed further, am I audible to everybody?
Yes, doctor.
Yeah, thank you so much. So, this 82-year-old female, she presented to us with lower abdominal pain, and this pain was for past 2 years, and it worsened since the last 2 days. In addition to the pain, she also had loss of appetite, fatigue, and weight loss. So, coming to the history, the patient tells us that she had a lower right abdominal swelling since last 2 years, and she had this pain of dull nature on and off. The pain worsened over the last 2 days, and she describes the pain as heaviness in her lower abdomen. Pain would aggravate when she was walking or lying on the left side of the body. The relieving factors for the pain was when she was sitting up, when she was lying on her right side, or after she passed her motions or urine. The pain was also accompanied with bloating sensation. She had decreased appetite, nausea, and also back pain. When inquired, she said the intensity of the pain was initially 4 on NRS scoring. It was 4, and now since the last 2 days, it has increased to 10. This was the first thing that brought her to our setup. So the other things that she also mentioned was that she had generalized fatigue since the last 2 months. But when inquired more, she said that she could carry on her day-to-day activities with the help of her caretaker. Her caretaker was her unmarried daughter, and also she used a walking stick. She had decreased appetite since last 3 to 4 months. That is a long time. So she now prefers to be on semi-solid food. And at every meal, that is breakfast, lunch, dinner, she would just take 3 to 4 sips of whatever meal that was prepared. She passed urine 3 times per day. There was no burning, no high colored urine. She passed stools every alternate day. And patient as of now was ambulatory, so there were no pressure sores. Only she said her sleep was disturbed because of the pain, and she was also worried of her daughter's future, so she was constantly thinking about it. Past history, this patient has been a case of diabetes and hypertension since the last 35 to 40 years, but she was on irregular treatment. She had abdominal pain, which was dull in character, and it was more on the right side, and this was over 2 years. And when it worsened, she would go to a nearby health center and she would get pain injections and feel better. When asked why she did not take an ultrasound examination that time, she said that there was nobody to take her to a high center, and on herself she could not go because of her age. She has an unmarried daughter now who has left her job since the last 6 months to take care of her, and they are both managing on the daughter's savings. Now, what happened 6 months back was this 82-year-old female developed a pain, sudden abdominal pain, and for which she was referred from that primary health center to a tertiary hospital on emergency basis. So here, when the ultrasound was done, she was diagnosed to have a right cystic ovarian mass, approximately 14 by 10 by 9 centimeters, and it had solid projections. She also had pyometra and uncontrolled diabetes, and the patient was in diabetic ketoacidosis. So she was taken for pyometra drainage and admitted in the tertiary hospital for further investigations to be carried out, and also because of her uncontrolled diabetes. So when she was admitted on the fourth post-operative day, she had an acute coronary event, which was managed conservatively. Now, all these events were managed by herself and the daughter alone. There was no other family support. So, what the daughter told us was when the patient was being taken for surgery, She was asked to sign on a paper without giving proper information. She was just told that the mother would die on table. It was a risky surgery. Anything could happen. And she was not given time to think about it. As it was an emergency condition that time. So she signed the paper, but it was a stressful day for the daughter. So she kept on crying throughout her mother's surgery. So, once the surgery was done, the gynecologist had suggested that another operation had to be done, but this would be done after the patient's diabetes was under control and after the anesthesia would give a fit for surgery declaration. But the daughter did not further wanted to do any investigations because of the emotional stress that both had to undergo. So they left the hospital as DAMA, discharge against medical advice. So now what we are thinking is probably it would be a surgical resection of the ovarian mass in order to further know about the histopath and later on chemotherapy. So now, present scenario, we examined the patient, and the patient was conscious, cooperative. She was oriented to time, place, person. Patient was thinly built, and she had pallor, suggestive of anemia, and there was no jaundice. Patient also had pedal edema, bilateral, and it was pitting in nature up to the ankles. She did not have any fever. The rest, everything was normal. BP was 146 by 80. So on systemic examination on per abdomen, we found that there was an abdominal mass on deep palpation, and it had irregular margins, and also the surfaces were adherent to nearby structures. So approximately the size was 16 centimeters by 10. So according to the USG, it was showing 14. Now it had increased in size, and there was tenderness also. The rest of the systems were normal. So we did some examination, and I would like to mention here that as is a primary health setup, so we do not have an ultrasound. So on the routine examination, we found that hemoglobin was 8.6, that is, she was anemic, and the diabetes status was uncontrolled. RBSL was 200, FBSL 160, and postprandial was 260. Her HbA1c was 10.3 grams. Her renal function test was all deranged. That is, blood urea 43 and serum creat was 1.6. The patient did not want to do an ultrasound. She just wanted pain relief, nothing more. So treatment was started. We gave her a symptomatic treatment. Also, her routine medications was restarted. So I'll just summarize. Injection pen 40 on them, act rapid injection, 6 units thrice a day. Injection degludec, 4 units at night. Antihypertensive metoprolol, ecosprin, stator, and cyclopam she was already taking. So for pain, we started her on injection paracetamol 1 gram, and we realized that there was no significant relief. The pain score NRS was 10. It remained 10. She said there was no relief at all. So injection diclofenac 75 milligram was given twice a day for that day, and the NRS improved from 10 to 7. But when we realized we got the reports of RFTs and they were deranged, we tried tablet Ultraset. As that time, the injection tramadol was not available in the primary health center. So when we tried Ultraset, which is a combination of tramadol 37.5 milligram and paracetamol 325 milligram, it was initially started BD, and she had dizziness and nausea. So in addition to all her treatment, we gave her Ondem, which worked well, and she started tolerating tablet Ultraset well. So that was continued. Next slide. So psychosocial aspects for this patient. She's an 82-year-old widowed female living in a village, and her house is a kacha house. Her unmarried daughter is 52 years old. Now she has a son who is 47-year-old, but he's married and living separately in other state. he's not in contact with the lady or the sister, so he's not caring or helping them. The unmarried daughter stayed back with the mother, and she was earning. She was working as a housemaid. She would work in some houses, but the houses were in the city, so she had to travel from the village to the city, and she would leave home at 8 a.m. in the morning, reach home by 6 p.m., and she had no breaks, no holidays. So now, because of the mother's condition, she has to leave her work. So she left her work since last 6 months, and whatever savings she had from her previous work, they are using it in the village. She's doing odd jobs and getting some income, but it is not steady. So the daily groceries they are managing from the ration stores, and they have, when asked about loans, they said no loans as of now. So that was one good thing on based on the finances. The mother is worried now because she's worried for her daughter's future. So she doesn't want to burden the daughter. So she tries to be ambulatory. She tries to manage her activities of daily life. But she's not aware. When inquired, she's not aware of her diagnosis. She just thinks that God has punished her for her past mistakes. So we asked her what past mistakes. So she said she was married to a man who was already married before, and she thinks she blames herself for the husband leaving the first wife. So she thinks that is her mistake, and gods have punished her. So she told us after her husband died, she started having many diseases. So she had diabetes and hypertension during that time. Then the daughter already knows that the patient has a terminal illness, and she doesn't want to take further invasive treatments considering the mother's age, because she's the only living family member that she has right now. And but she also thinks that she has wasted her life taking care of her mother, and she has not done something better for herself. So she feels guilty. Now, the daughter doesn't want us to tell the mother that she's suffering from cancer because of the cancer stigma. She told us that, doctor, don't tell her that she's suffering from cancer. If she comes to know that she's suffering from cancer, whatever daily activities she's doing, she'll forget, she won't do it, and she'll lose confidence in herself and be bedridden. So that is why she told us not to tell her, divulge the diagnosis. So the communication difficulty that we faced were, ours is a primary health center, so we have a busy OPD from 9 a.m. to around 3:34 p.m. So there's one doctor dealing with around 130, on an average, 130 patients. The medical officer per se is not a gynecologist or an oncologist, so we could not like prognosticate. Now, considering in this patient, she was an old lady, so this patient we could prognosticate looking at her general condition. But rest of the cases wherein the patients are very ambulatory, doing their routine activities well, and still having a diagnosis of cancer, and since palliative medicine is going hand to hand with curative, we can't directly prognosticate the further course of treatment or outcome. So as to like how long I have left doctor, for how many years will I be survive. So we can't answer those questions directly. Then we also don't know whether just taking palliative is going to prolong his lifespan or improve his quality of life, or he should take invasive care also. So we are not sure whether to tell him to just stick to palliative treatment or continue his whatever curative treatment that he's taking. So in this case now, the patient is not aware of her diagnosis, so thinking that this is a punishment from God. We don't know whether we have to like shake her beliefs, the false beliefs, and divulge. But here in this case, the daughter did not allow us to tell the mother about the diagnosis, and she always preferred to speak in hushed voices, and kept us like going from the patient and spoke to us privately. Here in this case, I would not say empathize, because doctor could empathize, but the doctor could not share the diagnosis with the patient. So that was the communication difficulty that we faced. Is everyone with me? I'm only speaking to myself.
Yes, Dr. Kalyani. So I would like to say that we are running short of time, and if you
Yes.
can be a little more brief, we can end
Yes,
this
another
and then
two
go on with
slides
the
to ready.
discussion.
Yes. So the main concerns here were the pain, the decreased appetite of the patient, patient not aware of a diagnosis and feeling guilty for her suffering, depression, cancer stigma, and also daughter's guilt feeling leaving job. Next slide. Summary. So this is an 82-year-old woman with diabetes, hypertension, ischemic heart disease, right ovarian malignant tumor. Also, she has anemia, cachexia, abdominal pain, fatigue, and not aware of her diagnosis. Then same things that I mentioned before. Unmarried daughter who has left work, financial difficulties will be faced later on once their savings are exhausted. And also, the daughter does not want the mother to know about the diagnosis. So we don't want the patient to die in facing guilty feeling. So we are also facing a lot of guilt now. Next slide. Discussion points are the same that I mentioned as communication difficulties. So yeah, busy OPD, medical officer not being a specialist, patient not aware about the diagnosis, and what all can be done for the patient. And sorry, there's a typo here. The patient and the daughter.
Thank you, Dr. Kalyani. Participants, you can post your comments in the chat box regarding this case. And I would invite Dr. Surendran and Dr. Revathy to give your inputs on the same.
Revathy, can you give your thoughts? Then I'll give my comments, and maybe we can open up discussion with all the other participants as well.
Okay, so what we did, sir, in this scenario was the first point mentions a busy OPD. So what we did was we started her, took all the history, we spoke to her passionately considering her state, and we also started 1 gram of paracetamol for her, and we told her, keep for 1 day you get admitted with us so that we could get time to finish the OPD. And then later on, once the OPD hours were over, we could go patiently sit with the patient and discuss the further treatment or further whatever doubt she was facing. So that was one thing that we could do in order to bypass the first communication difficulty, that is busy OPD. So we got her admitted, and then we had a lot of time to like sit with the patient and discuss the further course. Only we were facing difficulty when the doctor asked us not to divulge the diagnosis with the mother. So that was the only thing where we were facing difficulty. Although we tried to like tell the daughter, once she knows the diagnosis, she'll know that it is not herself to be blamed. She could also, I don't know, this cancer has a stigma. They just feel that it is a punishment from higher sources. So that we wanted to clear from her side.
All right. Dr. Kalyani, thanks for the case detailed case presentation, and also my thanks to all the doctors who raised question in the previous session as well. I was listening to them. I think the first Dr. Vincent asked about disclosure, right? And also Dr. Dilip also asked about too many people ask questions, and the other one was about disclosing the diagnosis and the medical. I think your case also revolves around the same. It's about disclosure of diagnosis. See, more than legality, more than empathy, if you ask, I would say it is ethical. Whether is it ethical not to disclose the diagnosis or prognosis to the patient? But I'm damn sure this is not the case to talk about diagnosis. This is, I think, about the prognosis. Am I right? Or the diagnosis? Dr. Kalyani, ma'am?
Yes. If we consider autonomy, which is one of the 4 pillars of ethics, then we do have to tell the patient the diagnosis.
Exactly. So without consent, you can't do any further. That is where the legality also comes into place. whether it is any requirement, the first thing is to educate the patient. So where does this leads to? The problem is two things. One is caregiver burden. So they are already burdened. They worry that what if the patient collapses? I think Dr. Vincent rightly pointed out. No, not Vincent. I think Dr. Dilip. If you tell, they might collapse. They may, withdraw. He said the patient is completely bedridden. It is the withdrawal. The patient withdraws completely, doesn't want to connect with the world. So when you tell that you're all right, then again they resume normalcy. It's not normalcy, at least back to the routine. So in this context, I would suggest there are two things to look at it, doctors. One is your burnout and your compassionate fatigue. Okay. So you already pointed out clearly 130 patient in OPD. If you open up this, what if the patient breaks down? Do you have time? That is why the referral system is very, very essential. Nowadays, oncology is a teamwork where you need to have the right person to do that. So I'm 100% agree with you. I'm in line with you all. You may not have time to sit and talk to a patient for 30 minutes, not even 10 minutes. So it needs more of communication, not just the, talking about the diagnosis, it is beyond. So in such a scenario, you need to identify a team member who can handle these issues, who are trained to handle. That is the first thing. To add to this, in this case of this lady, both the mother and daughter, and the daughter is not married, and the mother has a guilt. And again, it's again the stigma. You clearly emphasized about the stigma. Considering all those, I think I would say more than the patient, the daughter needs support. First, we need to sit and listen to her, help her understand the why the mother needs to know about the diagnosis. Then you initiate the discussion with the mother and follow the communication process, and definitely they will be able to understand. As Revathy ma'am pointed out, once you disclose the diagnosis, whether it's diagnosis or prognosis, it will be easy for the entire, the team. I'm talking about the doctor, patient, and the caregiver. In the triangle, all of you will feel ease when the communication process is complete. And over to Revathy, and I'm happy to respond if you have any further questions.
I would like to add a few points to that. So, as Dr. Surendran said, it is very important and vital to disclose a bad news to a patient or news for the patient. Especially when we are trying to plan a comprehensive care of plan when a patient is in advanced disease or end of life phase. And more importantly, before proceeding to that step, I would advise you to understand what exactly the patient state of mind is and what exactly the patient wants to know, because you had mentioned that the patient thinks of this as a punishment from God. So that was repeated in a couple of places. So where you said that patient was telling her telling that that she's been punished by God with this problem. So what exactly is she viewing this disease as right now if she is not aware of cancer, and why exactly does she think that way? So because I think there's a lot of regret or guilt factors that patient is uh, you know associating this current illness with. So if first that can be addressed to and asked, what exactly is it going on, and then probably if the patient wants to know more about this illness, because that was not reflected in any of the place, the patient's state of mind and patient's need for information, I don't think that was if it is explored or not, or even if it is explored, that was not mentioned. So based, I think we have to assess the need for information, and then provide the information accordingly, along with significant importance to the patient's emotional state of mind as well, because already there is a factor of guilt and regret in the patient where she thinks of this as a punishment. I think just providing the information alone would not be sufficient, in addition to paying equal importance to the psychosocial state as well. So I think, that is important. And as Surendran sir had mentioned, an exclusive session with the caregiver, with the daughter, is even more important, because she is the one who is going to deal with the patient henceforth, because she herself has a lot of emotional issues going on. So in addition to that, you can't just drop the bomb on the patient and then help her deal with the patient on her own. So we need to help them understand what is the importance, and also provide reassurance that as a medical team we are going to be here, and why is it important to discuss about this, to the extent that the patient requires the information. So I think that's it that I would like to add.
Thank you, Dr. Revathy and Dr. Surendran, for your wonderful comments on this presentation. Participants, do you have any more questions? Meanwhile, I could see one question from Dr. Upakul. I think that can be addressed in the next session on breaking bad news in detail, because he's asking about what should be done if relatives do not want to disclose the diagnosis to the patient at all. So I think the part two of communication session is on collusion and breaking bad news in detail, where where Dr. Revathy and Dr. Surendran will be helping you all with all of that. So I hope that answers your question, Dr. Upakul. Anything else? So meanwhile, Dr. Kalyani, I would say it is a wonderful case that you had brought today for discussion, and it was very detailed. I think you have looked into all the aspects of total pain, especially. And as a physician, I would like to comment on the pain part, because as we can see that the numerical pain rating scale was from 10 on 10 to 7 on 10 and then 4 bar 10. So I would have advised something like a morphine trial when the patient had come to you with an acute episode of pain, which was 10 out of 10, which is the worst possible pain. So for severe pain, I would say you could have started with morphine, but then I also understand the unique challenge you have coming from a primary health center. And yes, you have addressed in the most possible way that might have been easy for you. So you have given paracetamol initially, then moved to tramadol. So even with the dosage of tramadol, I would say you could have increased it up to 300 milligrams in a day. Maybe you could have started with 50 milligrams TID. That would have helped her even more. But then I was happy to see that the patient had a pain score from 10 on 10 to 4 bar 10. That is considerably a good thing. And there were definitely unique communication challenges with this patient story, especially that we were able to see. And you had brought all of that into consideration. And those doubts and queries were answered by Dr. Surendran and Dr. Revathy wonderfully. Thank you so much for bringing in such a wonderful case. Anything else? Dr. Revathy, do you want to comment anything more?
No, I also would like to appreciate the case, because that was a very relevant case for us for the session, and that has triggered a lot of questions. And I think we would get more inputs for this case in the upcoming session as well, because as we go through the stages and breaking of bad news, I think we'd be able to get more comprehensive responses. I think that would be more benefiting as well. So thank you so much, for bringing such case, and also thank you for the opportunity, for inviting us to be a part of this.
Thank you, Dr. Revathy and Dr. Surendran. I think we can close the session for today, and we can meet during the next session with a wonderful case presentation, I hope. Thank you, everyone, and I hand over the session to Gayatri.
Thank you, Dr. Revathy and Dr. Hashmat, for the wonderful session. Thank you, Dr. Surendran, for joining us. Thank you for all participants for the participation and your timing. I hope you all find this session much informative. And we are looking forward to see you on the next session. Thank you.